أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. Today I want to discuss something about the interpretation of the liver function tests. It is for the final year actually students or third year students, because very basic knowledge has been provided, although it is needed in the examination, higher examinations. Otherwise you cannot interpret LFTs. You don't know this. So it is for all, for me, for you, for all. I am Professor Sayyid Ali Azhar, you know that. I am the visiting professor of medicine, Janassin Medical University, and I am working on online lectures without any charges, just to spread my knowledge and my experience. Before going forth, now this is, which is here, try to understand this. The metabolism, that is RBC, is at 120 days, or plus minus, you can say 110 plus minus 20 days. It is the life of the red blood corpuscles. Then apoptosis occurs, that is the old RBCs should be gone, should die in itself. Now it died actually in the system which is called the reticular endothelial system, captured it, spleen and the corpus of the liver and the lymph nodes, all are in the body. It is divided down into heme parts, is separated from the globin part. Globin is a essential, one of the amino acid, and it joins the globin pathway. The heme will, in the presence of the heme oxygenase, it will be converted into biliverdin there, and then it comes into the blood. There is a biliverdin, according to one study, biliverdin will associated with a carrier protein, and it will come into the liver, and where the biliverdin reductase will convert this. This is because unconjugated bilirubin is entering into the liver cell. Well, it is biliverdin reductase actually, which is converting into biliverdin, unconjugated bilirubin inside the cell. It is the parts which is played by this, the reductase. Then inside the liver, when it reaches inside, the system, the enzyme system of the liver will convert. The conjugation occurs with the protein. The other proteins which are present in the liver cells, hepatocytes, UDPGT, that is the uridine diphosphate glutamase, will combine with the unconjugated bilirubin. It will convert it into the conjugated bilirubin. Then it will go outside the cell by exostosis, and it comes into the biliary tract and the biliary tree, I will say. That is interstitial spaces which are connecting and converted into the into the small canaliculi, the biliary canaliculi. They are joining and forming the right and the left hepatic ducts, joining with the cystic duct to form the common bile duct, is entering into the intestine, where it is converted by intestinal bacteria, by the enzymes. They are producing the coliforms into urobilinogen. Most of the urobilinogen will go again and absorbed and reabsorbed, and again the cycle will be converted as previously described into the liver, and 10 to 20% will be excreted as stercobilinogen in the feces, which gives the color, specific color to the feces. Now this is elaborated in this diagram. It is a schematic presentation. Senescent RBC, hemoglobin released from the RBC inside, and that hemoglobin go to the other part. Heme will come here, and it is here in the reticular system. This is what is seen here. Is the biliverdin reductase. Heme oxygenase is needed for the heme to convert the biliverdin, and then this system, the biliverdin reductase in the macrophage, will convert into the biliverdin actually. So you need the heme detachment, the breaking of the heme by heme oxygenase, and the broken part will be converted into another compound with a coloring agent, that is biliverdin. And it is the reductase, because the reductase NADPH will definitely go into NADP. This is the reaction, chemical reaction. The biliverdin actually, which is entering now into the liver, is an unconjugated form at the part, and it needs that enzyme. The unconjugated biliverdin, it is the enzyme which I will already mention out, the urine glutamase, diphosphate glutamase, UDP, glucuronate, converted into UDP, unconjugated bilirubin will be then conjugate. It is called conjugated bilirubin, and the cycle repeats as I said previously. It means that if the more substrate is there, this is called hemolysis. The hemolysis is there, if much hemolysis is there is a burden on the liver then, and it will converting definitely into the biliverdin and then converted into unconjugated bilirubin of course. But it is so much pressurized the liver, all biliverdin will not be able to convert into the unconjugated bilirubin, conjugated bilirubin. So unconjugated type of the bilirubin will again absorbed and come into the blood. This is unconjugated bilirubin, because it is a part which is played before the liver. It is called the prehepatic jaundice or hemolytic jaundice, you can say. The other one, which is when it is conjugated inside the liver, and there is disturbance which is going on in the liver cells. Some part will be conjugated, unable to conjugate. The mixed type, the unconjugated and conjugated bilirubins are much in amount and will be expressed in the lower, in the blood, and that is called prehepatic jaundice. It is hepatic jaundice or hepatocellular jaundice, because the liver cells are destroying. They are not able to function. Structurally, they are not able to function, and functionally, they are weak to do the conjugation properly. So burden occurs, and both type of unconjugated and the conjugated bilirubin, with a small differences, will be seen in the hepatocellular type of jaundice. Excretionary system of the liver, that is the biliary canal cry, will be the other part. When it is compressed at that site, biliary canal cry, or the right or left hepatic ducts, or at the level of the bile duct, or at the end of the bile duct, wherever it is, then the conjugated bilirubin is not able to excrete into the intestine. Then the conjugated bilirubin will be increased in the blood. It will be reabsorbed, and this is called post-hepatic jaundice. The post-hepatic jaundice means the obstructive jaundice. It means, or hepatocellular jaundice, which I said that is the liver cells, they are not functioning and they are not able to excrete properly the mixed type of the conjugated and unconjugated bilirubin. Then it is cholestatic jaundice. That is. So these are the you have to repeat yourself before going to see any liver function test. So what we'll do is this: the liver function test we'll do is, other than the CBC you have done. In cases of the liver function test, and there are manifold. Total bilirubin should be there. First of all, normally it is 0.1 to 1 milligram. More than 1.5 milligram, but less than 3 milligram, total bilirubin is called what is known as the latent jaundice. It is not appear in the clinically. More than 3 milligram is needed to appear in the sclerae or to appear in the nails, etc., or skin. Conjugated is less than 0.2, so you minus it normally from 1 to 0.6 to 0.8 is then unconjugated, the normal values. And then you see this enzyme. Afterwards, you have to look this, and that is very sensitive index is AST, where actually the conjugation occurs and the enzymes are there. Its normal value according to one lab is 31, 35, no problem. For 40, insignificant. More than 40 is actually significant. ALT and AST. This is ALT, the same values, is 5 to 35. Here it is about 5 to 31. So it is more than 40 or 45 is needed, ALT, for the significance, or AST or ALT. Both enzymes are important. If they are increased, it means that the conjugation is not properly done and they are releasing into the blood because they are unable to maintain their position into the liver. If it is increased, it means that hepatocellular jaundice. It means the cholestasis occur. It means that the destruction of the liver cell. It is hepatic jaundice. These enzymes are very important. As far as the other enzymes are concerned, outside the liver cells, but before they are going outside the cell, is the gamma GT. Gamma GT is another enzyme which is not written here but is important. If it is increased manifold, it indicates that this cholestasis occurs, stasis occurs, although obstruction occurs, but inside the liver, not outside the liver. Another enzyme of this obstructive nature is which is called as alkaline phosphatase. It is usually in the range of 25 to 112 international unit. If it is higher according to the age, because it is needed in the teenagers, 300 to 350 may be normal, or more than 400 are normal even, I would say. This alkaline phosphatase is non-specific enzyme, but it indicates in the case of jaundice that it is obstructed nature of jaundice and it is outside the liver which is involved. The gamma GT, if it is manifold, this is also increased. It means that inside the liver it is disturbed. This is the research shows this. I am not saying it. Although it is not written in the book very clearly. The other test we do here on the albumin, which is the functional nature of the test, normally 3.25, because there are many functions of the liver, and one is to protein synthesis. Albumin is the basic protein. It should be 3.5 to 5, and then the total protein is about, you can say, 5.5 to 8.5. So minus 8 you will find the globulin. Whatever given is total protein, for example, minus albumin, you will give globulin part. The albumin actually is decreased in cases of the diseased liver, which is called hepatocellular jaundice. Albumin is reduced. Most sensitive test of the acute liver diseases are the PT, prothrombin time, vitamin K dependent, coagulopathy dependent upon the liver functions. Because all of this pathway, which is, of course, you know that it is the extrinsic pathway, and where it is disturbed, vitamin K is needed for the formation of these coagulation factors. They are disturbed. If they are disturbed, INR should be, they are normally 12 to 16 seconds, INR should be taken as a major component of the liver disease, acute if it onset. And you see the fate will depend on the prothrombin time. If INR is less than 1, it is okay, no problem. And somebody has a jaundiced, and you bill, this test will non-specifically will tell you that what will be the fate. If the INR is 1.5 to 2.5, it means that it is acute permanent type of hepatitis. Acute permanent hepatitis. Acute permanent hepatitis is the condition in which the liver functions, they are definitely disturbed, and PT is disturbed. PT is a very sensitive index. For the destruction of the liver cells, the AST is the sensitive index. But as the acute problem is concerned, and the due time, the prothrombin time is the most sensitive index. These two are very, very important. One, the AST and this one. So we do actually, because of the cost effectiveness, AST most of the time, to see the liver function, liver cells are functioning or not, and as far as the severity is concerned, we do PT. These two tests are the most important. In cases of the prehepatic type of jaundice, prehepatic jaundice means the hemolysis occurs. What happened is that the bilirubin will be definitely increased to 3 milligram, 4 milligram, because unconjugated hyperbilirubinemia occurs. Because the load is much into the liver cell, they are unable to convert to the conjugated. You minus it with the conjugate, minus this total, you will find that the unconjugated hyperbilirubinemia, which is predominant unconjugated type of hyperbilirubinemia, it is mostly likely to be the prehepatic jaundice or hemolytic jaundice. If there is the conjugated and the unconjugated, both are very, very similar, increased. Similarly, they are increased parallelly, and the AST and ALT are disturbed to higher levels, 200, 300, 400. Typical nature of the acute hepatitis, that is destruction of the liver, occurs, and it is hepatocellular or hepatic jaundice. Now this will show this. If you minus the total from this, then you find that there is a predominant or dominant conjugated hyperbilirubinemia. It means that the liver actually functions normally, although they function, but the excretory system of the liver is disturbed. Inside the liver, gamma GT will be increased. Outside the liver, the alkaline phosphatase will be highly increased. Parallelly, they will increase. Inside the liver, if there obstruction occurs, conjugated hyperbilirubinemia, dominant alkaline phosphatase, means that it is inside the liver, outside the liver. If it is the gamma GT which is highly increased with conjugated hyperbilirubinemia, it means that it is inside the liver. Although alkaline phosphatase is also increased, but not much level. Higher level value gamma GT is a sensitive index in cases of the cholestasis in the liver. Although obstructed, this is the nature of the post-hepatic jaundice. Alkaline phosphatase will be increased, gamma GT will be increased, slightly AST, slightly ALT, but marked alkaline phosphatase or marked gamma GT will be increased. Post-hepatic jaundice or obstructive jaundice. The acute phases, you do the PT to see the nature of onset, whether the destruction is how much it is. The PT will tell you whether it is acute hepatitis or destruction, whatever it is higher, it means that the patient is going into the acute fulminant hepatitis if you are not controlling and not managing properly. Some tests these are the pre-hepatic and markers and hepatic markers and post-hepatic markers. I have told you. Repeat it many times. You can understand then the liver function tests. The chronic nature of the disease will tell you about this, the synthetic function of the liver, the albumin, globulin ratio, total protein, total albumin. Albumin will not be synthesized if it is chronic illness. In chronic hepatitis, in cirrhosis, pre-cirrhosis, albumin will be not be able to secrete it properly from the liver. All these are all disturbed. And a mixed type of a picture may be seen, it may be obstructive nature of disease, may be manifold. Repeat it many times, this part, so you can understand it well. The liver function test. What do you mean by the hemolytic jaundice? It is called prehepatic jaundice. I am repeating it again. Here is the total bilirubin will be increased, but unconjugated hyperbilirubinemia will be there. Along with it, the liver enzymes are not disturbed. They are normal. Albumin, everything will be not fine. In the hepatic nature of the disease, because liver cells are destroying, here the mixed conjugated and the unconjugated picture is seen. Whether it is dominant conjugated or whether it is conjugated predominant unconjugated. But the ALT is much higher and AST is much higher. It indicates that it is the hepatic nature of the disease, acute type of hepatitis, destruction of the hepatocytes. This indicates this. And if you see there is a total bilirubin is increased and there is the dominant conjugated hyperbilirubinemia. Alkaline, the AST is slightly increased, AST is slightly increased, ALT is slightly increased, not much, not significant. But the nature is that the gamma GT is much increased. With alkaline phosphatase is also increased, but not very higher level. It means that it is obstructive nature of the jaundice. It is a cholestatic type of a disease, you can say, but it is the process is going inside the cell. For example, cirrhosis. But for example, if there is obstruction occur in the biliary tract, there is back pressure, and alkaline phosphatase is higher increased. It goes to 600 with the conjugated hyperbilirubinemia. Although gamma GT is also parallelly increased, but not much. In comparison, you can get the ratio with the alkaline phosphatase and the gamma GT. It is higher in cases of the extra hepatic obstruction, and the intrahepatic obstruction. This ratio is decreased because the gamma GT is increased rather than alkaline phosphatase comparatively. In this fashion, the obstructive jaundice can be explained. Chronic nature of the disease, you want to see best test. There are many tests because this is the easiest to do. Total proteins normally is 5.5 to 8.5. Here you minus it the albumin, which is normally 3.5 to 5. You will get the globin part. If the albumin is decreased to 3 or 2.5, it means that this nature of the disease which you have described is chronic in nature, progressive chronic disease. This is the part 1 of my session of the liver function test, and I will continue with the second part afterward because I will go in slightly slower pace so you can understand well my lecture and you can remember it. There are 3 parts of this lecture, so please tolerate it. Thank you to you. Assalamu alaikum wa rahmatullahi wa barakatuh.